Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. This episode features expert discussions on best practices for managing patients with advanced ovarian cancer. It is part of a larger educational program entitled New Perspectives in Ovarian Cancer, Current Paradigm and Long-Term Benefits of PARP Inhibitor Therapy. During this podcast, Professor Nicoletta Colombo from the University of Milan-Bicocca and the European Institute of Oncology in Milan, Italy, Dr. Philipp Harter from the Kliniken Essen-Mitte in Essen, Germany, and Dr. Alexandra Leary from Gustave Roussy Cancer Center in Paris, France, will discuss cases involving maintenance therapy with PARP inhibitors, along with the role of bevacizumab in the treatment of advanced ovarian cancer. For more information on Professor Colombo, Dr. Harter, and Dr. Leary, along with a link to the complete program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Here we have a 52-year-old presents with increasing abdominal girth, anorexia. She's got a high marker. Her scan shows she has ascites, nodules, and ovarian primary, no disease above the diaphragm, no suspicious lymph nodes. And she undergoes a diagnostic laparoscopy to evaluate whether she's eligible to complete resection up front. And she's got 4 liters of ascites, and her sugar Baker score is 30 to 39. And it's the surgical's decision that he would not be able to do a complete surgery up front, and therefore does biopsies, which confirm high-grade serous ovarian cancer. And we identify as well that she has a germline BRCA1 mutation. So at this stage, she starts neoadjuvant chemotherapy. She has 3 cycles of carboplatin and paclitaxel, has a very nice clinical response and normalization of her marker. And she has a surgical evaluation where she's had a very good response that allows her to achieve complete surgery at interval debulking. And the pathological specimen shows some residual disease, but a very good response even at a pathological level. So what would you do in this patient after a complete interval debulking? She has a known BRCA1 mutation. Would you give 3 more cycles of chemotherapy in observation, or 3 more cycles of chemotherapy in olaparib for 2 years, or niraparib for 3 years, or introduce bevacizumab and continue with bevacizumab and olaparib? So is observation alone after first-line chemotherapy ever an acceptable option for stage 3 or 4, even when they have a BRCA mutation? I remember when SOLO-1 was being designed, we thought maybe some of these patients don't need maintenance with PARP inhibitor because BRCA mutated is supposed to be more sensitive to platinum, has a better prognosis after platinum therapy. So maybe they don't all need it. Well, today we know that they do. And this is the data here just with placebo in the SOLO-1 trial. And you know what? Even with a BRCA1 mutation and a good response to platinum, their outcome is poor. Half of them relapse within a year. So as Philipp said, advanced stage 3 or 4, even if they have a mutation, no maintenance is not an option, especially when you see the data that Nicoletta showed with the tremendous 42 months improvement in PFS when you give the olaparib as maintenance. So observation is not acceptable, and I think that's quite clear. Does it matter whether they're high risk or low risk? And here Nicoletta has already defined what we mean by clinical high risk or low risk. And here's because with bevacizumab, we became used to thinking that it was the higher risk patients who derived the greatest benefit. But here in SOLO-1, when you look, these are all BRCA mutated. If you look at the higher risk or the lower risk, the hazard ratios are the same. And again, because even what we thought were better risk patients, they have a BRCA mutation and a lower risk, they still relapse. So clearly, no matter their clinical risk, all these patients need to have maintenance. And here it's coming back to something Nicoletta said earlier, that even if we don't see residual disease, treating minimal residual disease after chemotherapy, after surgery, even in people with no visible residual disease, we have to do it. And that's because we're hoping we're curing. The PFS in SOLO-1 is really flattening out at roughly 50%. We're hoping some of these women are actually cured. So observation is clearly not an option. Then we have the option of giving a PARP inhibitor as maintenance. Okay, and here we have 2 options, olaparib or niraparib. And if you look at what's the benefit in other trials with PARP inhibitors when you give maintenance in the BRCA mutated subset, so this is only the BRCA mutated in PRIMA and all of the patients in SOLO-1. Again, The hazard ratios are really quite similar, okay, 0.33, 0.44. If you look at the median PFSs, they're lower in PRIMA, but that's normal. As Nicoletta stated, these were much higher risk patients, so they will have a shorter PFS. But clearly, a PARP inhibitor maintenance in BRCA mutated, we have all the data we need. And then the last data is the one in the Paola. Again, just looking at the BRCA mutated, hazard ratio of 0.31. All these patients with a BRCA mutation need a PARP inhibitor. The question that's another one is, well, clearly PARP inhibitor, we need it, but do we need the bevacizumab in patients with a BRCA mutation? We don't know, is the honest answer to that. We don't have a head-to-head comparison of a PARPi alone versus PARP inhibitor plus bevacizumab in BRCA mutated patients. We have some trials that are being set up that might help answer that question, that are comparing a PARP inhibitor alone to a PARP inhibitor plus bevacizumab. But right now, we don't have that data, but we do have some indirect data that can help inform us. And this comes from phase 2 data. It's in the relapse setting. But here the point is if you look in this setting at what do we get with a PARP inhibitor alone versus PARP inhibitor and an anti-angiogenic. Here, this was in blue, olaparib alone versus cediranib and olaparib. Although the benefit is smaller, you still see a trend maybe for increased benefit. The problem is these were tiny, tiny subsets of these trials with only 24 patients per group. Then there is another study, the Avanova, which asks again the same question. We're in relapse setting, but it's just to see if biologically speaking, adding bevacizumab in BRCA mutated patients to a PARP inhibitor makes sense. And here you have the data in the BRCA mutated subset. This is with niraparib alone and the blue line niraparib and bevacizumab. And although it's not statistically significant because the patient numbers are tiny, there's a trend to improved benefit, suggesting that you do get additional benefit if you add bevacizumab to a PARP inhibitor in BRCA mutated patients. And it's just the patient numbers are too small to demonstrate synergy. What's the last piece of indirect data we have that even in BRCA mutated patients, adding bevacizumab may be of benefit? This is a population adjusted indirect comparison. These are 2 trials, okay? So the red line represents the patients in Solo 1, all BRCA mutated that received olaparib. And then the blue line is the subset in Paola 1 that had a BRCA mutation and that had similar clinical characteristics to the patients in Solo 1. And here you see suggests that adding bevacizumab to a PARP inhibitor in patients with BRCA mutation might improve benefit. So why would we put both up front? Some people argue it's a chronic disease. If you use everything up front, you don't have anything for later. Well, I think we have to maybe start being a little more optimistic and hoping that we are curing some of these patients. So I think if you believe that you might be curing some of these BRCA mutated patients and they have an indication for bevacizumab, then there can be a rationale for using both of our maintenance options in frontline. We're trying really to do our best to cure these patients. And so this is the treatment pathway similar to what Nicoletta showed earlier. Here, just focusing on BRCA mutated patients, where again, the first decision is whether you operate up front or you give neoadjuvant chemotherapy. The second decision is whether you give bevacizumab. And again, that'll depend on local reimbursements, contraindications. And then for those who are not deemed eligible to bevacizumab, if they have a BRCA mutation, you definitely have to put a PARP inhibitor in. You can put niraparib, you can put olaparib based on PRIMA or on Solo 1. And if you put the bevacizumab, then clearly there's an indication to add the PARP inhibitor. None of these patients with a BRCA mutation should have bevacizumab alone. Clearly, the PARP inhibitor is absolutely crucial. On that note, I will stop my presentation and see if there's any questions. Any of my colleagues think they would ever do bevacizumab alone in a BRCA mutated patient?
No, not for sure. Not even in HRD positive. I think we do know quite clearly now that the benefit of PARP inhibitors is really great. We have never seen anything like that in ovarian cancer, and this is true for HRD positive and for BRCA. So there is no doubt that you should use a PARP inhibitor in these 2 clinical situations or biomarker situation. What you said, I think one of the most important questions is whether to add bevacizumab to PARP inhibitors particularly in the BRCA mutated population. And I think this question deserves a prospective randomized trial, which, from what I know, the AGO group is doing, and also the gyneco is doing. So I think this question should be definitely addressed in a prospective way, and to compare a PARP inhibitor alone or the combination with bevacizumab, particularly in patients with BRCA mutation, because again, we don't have any direct comparison.
Exactly.
And the benefit from solo one is so huge with olaparib alone that someone may tend not to use bevacizumab. But once again, as you showed, there could be a synergistic or at least an additive effect, and particularly in a patient undergoing neoadjuvant chemo, so with bulky disease, poor prognostic factors. I think in this patient, I would probably use bevacizumab plus olaparib. Of course, you may argue in a patient with a stage 3 optimal cytoreduced whether to add bevacizumab or not. This, I think, is the most difficult. I don't know, Philipp, do you use also in patients with optimal cytoreduction the combination of bevacizumab and olaparib in patients with BRCA mutation?
Yes, we use also the combination in patients with BRCA mutation. So maybe coming back to your patient, if a patient undergoes an interval debulking, this is an automatic recommendation for me to use bevacizumab, because this patient is, I think, will mostly benefit from bevacizumab, and depending on the biomarker status, maybe additional benefit by a PARP inhibitor. But I think for the general population, especially if you don't know the biomarker status, you should always add bevacizumab. But I absolutely agree. Maybe we are in the future able to identify patients in whom maybe PARP inhibitor alone might be sufficient. But I think at the moment it is difficult to say if you have stage 3B, for example, or stage 3A, complete resection, primary surgery. We don't know at the moment, and we need the prospective trials to check if additional step is needed, or if PARP inhibitor alone is also.
But remember, as Alexandra said, that the first line treatment is the only options that we have to improve cure rate, unfortunately, because once the tumor relapses, then we won't have any possibility to. So I would tend to use the most in the frontline setting, try to improve the cure rate, because this is our goal. And having said that, unfortunately, I think we are coming to the end of this symposium because we are approaching our time. So I would like really to thank all of you for the very nice presentation and discussion of clinical cases, of interesting clinical cases. We all agree that the treatment landscape for ovarian cancer finally is evolving rapidly, and this is a good news for our patients, of course.
Thank you very much, Professor Colombo, Dr. Harter, and Dr. Leary, for that excellent discussion. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, New Perspectives in Ovarian Cancer, Current Paradigm and Long-Term Benefits of PARP Inhibitor Therapy, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.